welcome to an event at HUHPR. This is a part of the HUHPR Speaker Series. Where at Harvard Health Policy Review, we like to invite prominent leaders in the field of health policy and research to join us for the evening to speak about their work and career. My name is Min-Soo Kwan. I am co-speaker chair with my colleague Hugh Hankinson, and tonight we will be moderating our event with Dr. Rubin. The structure of this evening will be as follows. We will be hearing from Dr. Rubin, followed by some prepared questions, and then, of course, open it up to the audience for any questions that you all may have. So we're so excited to have Dr. Rubin join us this evening. He has been the editor-in-chief at the New England Journal of Medicine since 2019, previously serving as an associate editor for several years. He is also an infectious disease physician at the Brigham and Women's Health Hospital, member of the National Academy of Medicine, professor of medicine at the Harvard Medical School, adjunct professor and tuberculosis researcher at his Eric Rubin lab at the Harvard T.H School of Public Health. Dr. Rubin holds M.D. Ph.D. degrees from Tufts University, but also he is a Mather House alum as a Harvard College alumnus. So please join me in welcoming Dr. Rubin.
Thanks. One thing you may have noticed, thank you, Min-Soo, and thanks for the nice introduction. One thing you might have noticed about it is the health policy never got mentioned because I don't really know much about it. But ignorance has never prevented me from talking about something. So I just wanted to make a few remarks and get to things that you wanted to talk about. Does it sound funny, echoey to you? It's okay? All right, good. Okay, I won't listen to myself then. So, as you heard, I came to the journal. So my background is as a basic scientist. I have a laboratory. It has nothing to do with patients. I mean, we hope that eventually the things that we do will apply to patients, but I'm not even I'm a doctor, but I'm not a medical researcher. So when I came to the journal as editor-in-chief, it was a pretty big change for me because the journal is a clinical research journal primarily. So how does that matter when it comes to health policy? Well, I think an illustration of that is shortly after I took over and trying to learn how the place worked and trying to learn what an editor-in-chief does. And I know that some of you are dealing with being editors yourselves of the Health Policy Review. We had a minor outbreak of a disease, COVID, and that changed everything for us. Essentially, like the rest of the world, we had to turn over everything. The hospitals in Boston, the Brigham and Women's Hospital where I work, essentially changed to a COVID hospital. We stopped all surgery. We turned almost every bed in the hospital into a COVID bed. If you were a cardiology fellow or a pulmonary fellow, then you took care of COVID patients in the ICU all the time. And that was the entire experience for a year. At the journal, our experience was that we received more than 200 manuscripts, submissions every day, 7 days a week for a while. And as the person who reads them all, who did the triage, that was really painful. It meant hours a day just reading through to triage manuscripts. And so we did publish quite a bit. We published things that we wouldn't ordinarily publish because we felt strongly that we needed to provide some information, even if it wasn't the highest quality information. Some is better than none, and if we needed what we could get. So, but also this was happening on the backdrop of a huge social event, the disruption of society, the disruption of the economy, and it was impossible to ignore that. So along with publishing medical research, we published quite a bit on what the sort of social measures that might be important were. And I think that we, like others, were exploring what that would be. We published early on that masks probably weren't a good idea. That wasn't our position, but we published an article saying masking is probably not a great idea, and then sort of had to backtrack on that. And we published a lot about the kinds of ways that laws should be implemented around public health, given a scenario like this. And eventually, we even published an editorial signed by all the editors saying that the government's poor response, the U.S. government's poor response to the outbreak meant that we should, in the upcoming presidential election and presidential and congressional elections, throw the bums out. That they had done such a poor job and jeopardized so many lives that they didn't deserve their jobs. And some of them kept their jobs, and many of them didn't. But it had nothing. I think it had very little to do with our editorial. Nevertheless, that was the first time in the more than 200-year history of the journal that we'd taken a political position of that sort. So extraordinary times and extraordinary measures to go along with those, with the kind of pressures that built up. But of course, it's an illustration of what's important out there. We publish what we're good at, and what we're good at is usually large, randomized controlled clinical trials. In medicine, that's considered to be the gold standard. You take two groups of patients, you treat one way, you treat one the other way. They're generally blinded so that the patients don't know what they're getting. The treating physicians don't know what they're getting. So it's double blinded. And no one can see the data until the very end. And at the very end, those data are unlocked. There's already a plan for how those data, that's publicly announced, for how those data are going to be interpreted. And you follow that, you follow that plan. You're required to follow the plan that you laid out before you even started the trial. This gives you relatively high confidence information, relatively. And it's the best we can do. Now, and that's kind of our standard for everything that we publish, except in health policy. We don't publish a lot of health policy, in part because you can't do that. You can't say, well, we're going to establish a new policy or a law. We're not going to tell people what it is, but we're going to just do it. They're not going to know. And then we'll see what the outcomes are comparing the two groups of people. So in general, policy sorts of experiments are interventions where, are observational, non-interventions, observations where, for example, a law got changed, what was the effect of that on people's health? And the sorts of tools that you use for that kind of investigation are super different from the ones that you use for a clinical trial. They're usually tools that are used in economics as opposed to tools that are used in medicine, things like difference in difference analyses, kinds of things that we, as physicians or as physician researchers, aren't so comfortable with. The upshot of all of that is we don't publish that much research in health policy. And it's something that I think we wrestle with constantly because it's such an important part of what we do, but it's hard to compare it with the kinds of medicine that we publish. We do, however, publish quite a bit of policy, of discussions of policy. And they're published usually in a section that's a more editorial section, a section called Perspective. And a lot of them are summaries of what is being done or what should be done in some policy area or in healthcare and health systems delivery, health systems in general. We tend to be provincial, something that I want to change. We're very U.S. focused. And as you know, health policy and healthcare systems are vastly different between countries, and those differences make anything we publish about the U.S. system almost meaningless in a lot of these other contexts. So, and it means that we are ceding a lot of important work to other places. At the same time, for those of you who have read economics papers, so our whole journal, a journal article in our pages is 5 pages long. An economics paper can easily be 80. That would take more than one of our entire issues. So we're not prepared to publish that sort of thing, and our readers wouldn't be able to understand them. So we're catering to physicians, and we're trying to get policy. When we think about policy, we're trying to get it in a form that our readers can understand. We try to do that with clinical research too, because remember, most of our readers aren't clinical researchers; they are doctors. So we're trying to make something understandable. I think it's something that we have to keep on working on, because health policy is profoundly important in our country. Even though I said we're provincial, in our country we do a very poor job of it. And as all of you know, in the U.S., we spend more money than anyone else does, and we have relatively poor outcomes as compared to many countries that are spending a lot less. So right off, we're not doing that well. We don't have a great life expectancy. We have very unequal treatment of different people, and we have relatively high rates of infant mortality, particularly in some communities. So we're not doing well. I think we'd like to help be part of that solution. I'm not sure we're the perfect people to do it, but we'd like to encourage it. And I'm glad I can't believe so many people are interested in health policy. That's fantastic. It's a super important thing to do, even though I'm not smart enough to do it. I'm going to end there. I'm sorry, I don't have any profound remarks to make. So let's have a discussion instead. Great question, and I'll repeat it just because I know that we're recording it. The question was, are we involved in discussions with authors, with researchers before they submit a paper in earlier stages of a study, number one, and what does that mean for studies with negative results? Generally, the answer is sometimes very early on, but very often later on during a study. So we often will hear about studies where authors will contact us about studies before they're completed, to say, is this something we're interested in? And really the best barometer has to do with negative results. It's easy for us to say, yes, this is something we're interested in, no matter how it comes out, because they're asking an important question. And if the methodology is convincing, then we are interested. And sometimes we'll go as far as asking them, remember that this sort of research is very scripted. There's a protocol that they have to follow. And we'll go as far as reviewing the protocol before we see any data, and tell them, yes, we'd like to publish your article no matter what the result is, as long as you follow the protocol. So yes, and of course you can know about this years in advance, because many of these trials take years to complete. That is true for the very largest studies in general, which are and really the judgment there is hardly important. But it's generally true. If there's an important question out there, we're often willing to publish negative results. We publish a lot of negative trials. Not quite as many as positive, because they're not as exciting, but negative trials can have as much influence on medical practice as positive trials. Lots of times they're testing a question that everyone's asking, and so we think the negative result's important. This is a different sort of answer than a science journal would give you, because negative results generally aren't that interesting in a science context.
When you mentioned that you didn't want this job, and you know you would wear many, many hats, I was wondering, how were you offered this job, and how does one find themselves offered to be the editor-in-chief of the New England Journal of Medicine?
Okay, so the question is, how did you end up with this job for which you are obviously unqualified? I'll tell the real story, which is I was an associate editor, one of those part-time people. And I don't actually know how I got that. Someone asked me to review some articles, and they said, hey, we need an infectious disease editor. And I had to learn on the job because I didn't know anything about clinical research at the time. But I'd been doing it for a while. And the old editor-in-chief, who'd been there for 20 years, announced that he was retiring. The week after that, I was sitting with another one of the associate editors, and we were speculating who in this room could be the EIC. And generally it's not, generally they'd go outside the room, it would be someone from elsewhere, but we came up with some ideas as to who might be a good editor. And as I walked out of the room, the old editor-in-chief said, oh, I overheard you. How about you? Would you want to do it? And I said, well, I'm really not qualified. And he said, no, I think you should do it. And then I got some calls, and they said, you should apply. So I applied. I thought, I agonized a lot, but then I applied. But I really didn't think I wanted this job because I didn't want to lose my old job. So they brought people in, they had this big search process, they had a committee of, they hired a firm, they had a committee of 20 people, all 4 of the medical school deans from Massachusetts were on that, which was interesting because I'd been on the search committee to hire the HMS dean. And then, and we interviewed, and the questions they asked were like, how do you handle crises? I mean, I'm not much of an interviewee. They said, how do you handle crises? And I said, can't think of a crisis that I've ever handled. I was terrible, honestly. And I walked out of there, went home and said, I don't have to worry about this anymore. I said to my wife, no worries, I don't have to worry about this job. And in fact, I didn't get the job. They shortlisted 3 other people. And that was it. I didn't hear anything about it for another 4 or 5 months. And then I got a call saying, actually, we don't like any of the other people, but we like you better. But it didn't seem like you wanted the job. And I said, well, I kind of like the job I have. They said, well, what if you could keep the lab? This was getting back to it, to the question, to Sue's question earlier. And I said, okay. And so I think I was not their first choice. So I kind of backdoored into it. But it's really super interesting. It's a really good job. So I'm really glad that it ended up that way. When I was sitting here, well, I never sat actually, but when I was saying in St. Sieber, where I did take some classes, did I think I was going to be the editor-in-chief of the New England Journal? Did I even know what that job was? No. But if I thought about it, no. I mean, it wasn't anywhere on my radar, and it wasn't anywhere on my radar even when I got asked to apply the first time. So things happen, and they turned out well. I think I'm not much of a planner, and that would be my entire career is randomness.
Hi. So you mentioned earlier how during the time of COVID, you were obviously kind of triaging articles about the pertinence and the importance because you were putting out the information for physicians to properly care for patients. So kind of on your day-to-day, how do you decide which medical issues are important and which research is most important to publish given the current issues of medicine today?
So the question is, given so many different topics that are out there, how do we decide which ones we're going to publish? The answer, of course, is first off, an important part of that is we're a little bit passive, right? We do try to reach out to people and say, please send us your manuscript if we know they're doing something. But 95% of what we get is unsolicited manuscripts. So we can't dictate what's going to be published. And we often find ourselves in the position of saying, well, this isn't the study I want to publish. I want to publish this study, but we don't have that study. It doesn't exist. So we're constantly making these apples and oranges comparisons. Do we want to publish a big cardiology study? Do we want to publish a study that's a a cure for a genetic disease that only one person has, but it's really interesting. And the answer is we'd like to publish everything that's good. And so it's a real mix of things depending on what we've received and what catches our eye to some extent. In general, large clinical trials that ask important questions, we have first priority. But I'm a scientist, I kind of like the science-y stuff, so we do publish small trials, sometimes involving no more than one person, or case descriptions that are really interesting biologically. So a little bit of everything. We also have editors, remember, from different disciplines, and to some extent they're advocating for their discipline, so that we have someone in the room who says, this is the most important thing that I've seen in the last year.
At like a very high level, do you see a difference between physicians with an MD or MD Ph.D. like for their research quality? Do you think the extra years of training is worth it?
Well, the question is are the extra years of training worth it for an MD Ph.D.? Is there any difference? So MD PhDs are nerdier, I do think that this didn't used to be true, but it's easier to do basic science as an MD PhD. You get to invest the real amount of time in the lab. It gets a little harder with a strict MD. There are plenty of great MD researchers out there, but it's harder because of life things. You think about it, you go to medical school, and let's say you decide to do clinical training, so you do 3, 4, 5, 6 years of training afterward, and now you're in your 30s, you often have a partner, you might have children. The idea of going and spending 4 or 5 years, which is the minimum amount of time it takes to learn to be in a lab, it is hard at that point. Whereas when you're a graduate student, you get nothing to lose, you can make not much money, you can spend long hours in the lab, you don't have any other entanglements. So it's not the PhD, I think, so much that makes you better, it's the timing of that training that makes it easier to be a clinical researcher. I mean, to be a basic scientist. It's less true for clinical research. I don't think the PhD is as valuable or as important for clinical researchers, because you can learn that skill set in a limited amount of time. On top of that, large clinical trials involve lots and lots of people, so you kind of come up through the system ways, and you learn a lot on the job. My son just defended his PhD a few weeks ago as part of an MD PhD, and so he did not learn about masochism from his father, because it takes a really long time. It took him a lot shorter than it took me. Yeah.
With the advent of large language models, think like GPT, I was wondering if you could speak to two things. First, how AI, maybe text AI, and other forms of AI have impacted the operations at NEJM. You know, what you consider your job to be, what you consider the job of folks who are writing these articles to be, and also more broadly speaking, how you think AI will impact large clinical trials.
Okay, so the question's about AI, its role in the journal now, and the role in the future of clinical research. The role of the journal now is 0, but it's something that we think about a lot. And I think we think about it in 2 ways. First off, many journals have already announced policies on the use of tools like ChatGPT or other large language models. And several of them have come down with the idea that they're bad, that it's not that large language models are cheating. I don't feel the same way. I feel like what's important in our papers is what is the information that's there, not the wording so much. We're going to change the words anyway. And I'm particularly sensitive to people who don't speak English as a first language. They're at an incredible disadvantage when it comes to publishing. And you can hire, you can pay a coach $10,000 to help your English, or you can, for free, ask ChatGPT to do it. It seems crazy. Why not have ChatGPT improve your writing? I think you just have to own up to the fact that you use them. But remember that if you look at pharmaceutical studies, they're all written by hired guns. They're not written by the investigators. This is just another hired gun, but who happens to be free, as far as I'm concerned. So I think our policy is going to be very permissive. Admit what you did. This is for original research. It would be very different for an opinion article. I'm not sure we would be so inclined there, or for an essay. So I think, and as part of the publishing process, ChatGPT or GPT-4 now can do amazing things. It can read our articles, summarize them. It can look to see which, for a review article, it can look to see which references were omitted. We've done this. We've tested this. That, an important reference that the author should have included that wasn't there. So I think that as a tool for a publisher, it's going to be, or for an editor, I think it will be useful. Not just today, but not in not very distant future. For research, machine learning in general, I think less so large language models, but machine learning is already important in a lot of disciplines, both in basic science and clinical work. Really the opportunity to identify things that you couldn't see, that aren't evident to you, or you wouldn't have hypothesized to begin with. That's where machine learning has such strength. We're seeing it increasingly in used as a research tool and as a clinical tool. For example, let me give you just a couple examples. Someone comes into the emergency room and they may have brain swelling. It's a pretty bad thing to have. The easy way of telling if someone has brain swelling, instead of doing a CAT scan, is you look in your eye and you can see bulging from the brain at the back of the eye. Doctors are not so good, especially in the US, are not so good at looking at people's eyes now. And you can call an ophthalmologist, but there aren't that many ophthalmologists around in the emergency room at any given time. Or now you can use an AI tool that will, you take a picture of the back, it will take a picture of the back of the eye and analyze it and say, this person has cerebral hypertension. So I think tools like that are going to be very useful in the clinic with clinical applications. There are several of them that read X-rays, read mammograms, for example, and I think they're part of the future of medicine.
It's really interesting to hear you discuss Dr. Farmer, Dr. Rubin. A number of us have, I think, had exposure to his research, his teachings, his books, and an important part of Dr. Farmer's work was being a physician. And could you maybe speak to how being a physician takes its place in your life today, seeing patients, and how it informs your work at the journal?
So let me talk about me and let me talk a little bit about Paul also, because I think what you said is so very important in thinking about him and thinking about health policy, in fact. I feel like, seeing patients is really, I keep on coming up with fun. Again, I'm very profound. It's so interesting, and the opportunity to get engaged with people in that way is a real privilege. So I've always enjoyed it, and I've always done it even when I didn't get paid to do it. I still don't get paid to do it. But now I think it's also important as the editor of a medical journal to actually be there doing things. During COVID, I did a lot of work in the hospital. I'm an infectious disease doctor, the biggest infectious disease ever. It was important to be part of that. And I learned a lot from patients doing that. Paul was an interesting guy, and it's an incredible tragedy to lose him. But Paul came to public health in a very different way from most people who come to public health. He really saw every individual person as a patient. And I think you really encapsulated his philosophy when you said he looked at everything as a doctor. So when people would make the argument that, okay, we need to get drugs to Haiti, for example, and what are the drugs that Haiti can afford? He came at it in a very different way and said, hey, that is my patient. They need a heart transplant. How do we get a heart transplant for this patient? Not, it's crazy, how can you ever afford a heart transplant in Haiti? And this was really a moral question for him. It was, how can you talk about, he was very opposed to cost-benefit analyses. As you know, he felt that there's a moral imperative to care for people. You'll figure out how much it costs, and you figure out how you're going to pay for it, rather than figure out how to reduce, how to give less than adequate care. This was not when he came on the scene, this was not a popular idea in public health. I think it remains a sort of controversial idea. He had such a force of personality, though, that he really, I think, made this part of the teaching certainly for people interested in global health in general, if not public health overall.
Do you find yourself being more critical of submissions that are in your own field of research, such as tuberculosis research? I know you've mentioned before that New England Journal of Medicine only publishes 200 articles a year, and so each spot is quite precious. And given that you're so passionate about TB research, though, you might want to, publish more of those topics as well. So how do you balance those interests?
I try to balance it. Last year we published 180 TB articles. No. It's interesting. I'm going to generalize it a little instead of talking about TB. The process of publishing is papers get sent out for blinded reviews to reviewers, and they're experts in the field. And you end up with two very different kinds of responses. One is, this is the most important field ever because I work in it, and therefore we should publish the paper. And the other one is, this is the worst paper ever in this field, you should be publishing mine instead. So that field-specific thing is a big deal. Hopefully I have a little bit of perspective because I see so much right now. Fortunately, TB is a very happening area in clinical research. The treatment of TB is changing, and it will be completely different in 5 years than it is today, and it's already different today than it was five years ago. It's the only infectious disease, or the only bacterial infection, for which there is lots of real basic science, lots of industry investment, even though it makes no money. So I think we have been able to publish, it helps to be in the field because we have been able to publish the most important work in that field, both in treatment and in vaccines. So it happens that this is the right time to be in TB. 20 years ago, there was nothing to publish. Right now, there's a lot, and we're tending to get it.
Could you tell us a little bit more about what the review process looks like for those submissions? Do you all sit around together? What does that look like?
So if you submit, ours is kind of a standard review procedure, except it's a lot more intense. We have about 10 associate editors who are experts in their field, MDs, experts in their field, who spend 20% of their time at the journal. And then we have 10 people who are also experts in their field and are full-time editors. All but one are MDs. One is a geneticist, a Ph.D. So we have a lot of people thinking about every single article. The way it works is you submit an article, it comes to me, I decide if it's worth pursuing. If it is, I'll assign it to one of the editors. They then decide, they're an expert in that area, and they can decide, we don't want that, and they can reject it right then, or send it out for review. If it gets sent out for review, it comes back and the editor says, this is something interesting or something that we should think about taking. Then they bring it to an editorial meeting, which is that room full of people. When well, pre-COVID anyway, all the editors, both all the associate editors, all the deputy editors, all the statisticians would meet once a week in a room, and each manuscript that was being considered, and remember these are late stage, have already been reviewed, the editor who handles it would Xerox all the figures. This is really tree killing, but no longer, but would Xerox all the figures, hand them around, and present the articles, talk about why this is important, why did they do this, why is this a question that people are asking, and then present it like a journal club article, and then present all the reviews, and then we discuss all sorts of aspects of it. It can be the methodology, often the statistics, because the room's full of statisticians and we have to let them talk occasionally, the ethics, whether or not this was ethical, whether or not you can do a placebo-controlled trial for this, or whether or not they should have. And then we arrive at a decision whether or not we're going to take it. But that's not the end. If we say we're going to take it, we're saying we're going to take it if you make the changes, if the author makes the changes we want, and those can be pretty profound. Usually, we make them change the conclusions. Sometimes we make them change the conclusions to the opposite of what they said. So they will say this drug works, and we'll require them to say the drug doesn't work. Incredibly, mostly they'll go along, almost always, even companies that are producing that drug. And that occurs through an editing process, a back and forth between one of the full-time editors and the authors over the course of weeks to months before it's ready to get published. So super intensive process for us. And why is it for us? Because we spend a lot of money on that process, whereas most journals can't do that.
Unfortunately, I think that's all the time we have for questions this evening. Dr. Rubin, thank you so much for being here.